Our next speaker is Francis Crawley, and he is the Executive Director of the Good Clinical Practice Alliance, Europe in Brussels, Belgium. He is also Chairman of the Ethical Review Committee of the International Network for Cancer Treatment and Research, INCTR. He's a member of the Ethics Committee of the European Organization for Research and Treatment of Cancer, consultant to the Peking University Institutional Review Board, and a member of the steering committee of the Chinese Ethics Committee of Registering Clinical Trials. He is also co-founder and a steering committee member of the Strategic Initiative for Developing Capacity in Ethical Review. Mr. Crawley's research focuses on the ethical, legal, and regulatory issues in health research. Welcome.
Thank you, Madam Chair, and thank you to the members of the Commission. It's really an honor and a privilege to be here. And I was asked to speak today about transnational research, as with my colleagues here, but in particular to focus on good clinical practice. It was really a great privilege yesterday to be able to listen to you and hear what your reflections were. And I think Dr. Grady and then the subsequent discussion, as well as the discussion so far this morning, has given a very good and clear understanding of good clinical practice, both with regard to more or less, let's say, how it's situated with regard to research today, but also with regard to some of the questions that arise with it as well. For myself, I do appreciate good clinical practice. I think John will tell you that my real love is the Declaration of Helsinki. That's what I really, really do appreciate very much, as well as having worked on UNESCO, CIOMS, WHO, and other UNAIDS and so forth guidelines. So I really do appreciate this field here today. I just want to jump to the end of my presentation, if I could, or probably the end of today from what I understood yesterday, and the single word I will use is transparency. I very much want to really express my appreciation to Dr. Reverby, and in particular, but also to the CDC, and also to you folks here, as well as your staff and the work that they're doing with regard to the Guatemalan studies. I think this work, which Dr. Reverby has really done in an exemplary way, as an historian, as an ethicist, as a human being, to really show what's important here. And one of the things that Dr. Reverby has done, and now together with others in collaboration, including with the people in Guatemala, is to bring something out of darkness. And this is really very, very important for us. And this is what I would like to stress when I'm during my presentation here. First thing I would say, and really this is from my perspective in a good clinical practice transnational framework, if you want. Science is a public good. The pursuit and the results of science belong to the public, and that means not the public of this place or that place, these people or that people. It's really to humanity, as is very well stressed, I believe, also in UNESCO's guidelines. The pursuit of knowledge is an obligation and a responsibility. Now, this sounds very naive, but for me, I have a very strong question in my mind always. Why do we permit people to experiment on human beings? This is a very serious question. The answer is anything to me but obvious. What happened during World War II, what happened during the Cold War, what happened in Guatemala in particular, what happened in South Africa, what probably is happening right now as we speak in North Korea. So these are very serious issues, and I think we have to give an appropriate response. I also think we need to consider very carefully what we do as ethicists and as bioethicists. That is, are we protecting human subjects? Is that what we're about? Are we justifying research on human subjects? Is that what we're about here? Or are we advancing health? And how are we advancing health? What is it? What are our roles? And I think all of these are involved here. but what are our roles and what should be our principal objective here? I think, really, the principal objective has to be health. And I want to stress something as well, and I think Dr. Feinholz has already done that very well. Research is embedded. Research is not a standalone activity. It involves so many aspects of our society. So this diversion that we see with regard to our discussion, how to protect human subjects, how to do research, this can only really be understood when we understand, let's say, here in the US, how other things function, how healthcare functions, how health insurance functions, how medical education takes place, how hospitals function. That's the same kind of issues that we have in Belgium as well. This is why, for example, in Belgium, our GCP is quite different than our compatriots in the Netherlands or in France. So we have really, in a certain sense, to understand the context as well in which we're doing this. I want to state really clearly from my perspective here, and I think it is the perspective of GCP, research on human subjects is never a right. Now, we can talk about a lot of rights, we can talk about a lot of human rights, and we can even say the pursuit of knowledge is a right. And we've had a large discussion within bioethics, particularly during the 1990s in Europe, with regard to the relationship between the right to pursue science and the need or the rights of those individuals on whom science is being experimented. We need, I think, to complement a right-based ethics with an ethics of responsibility. In other words, we have to say, if you want to engage in human subjects research, you have responsibilities. And these responsibilities need to be clearly articulated and clearly engaged. I think it's obvious. There's a trust deficit with regard to scientific health research, biomedical research, clinical trials, however we call it. There's a deficit there with regard to the trust. This deficit is understandable, and we can explain it really very well here. I think the response that we have been giving, so I'm not saying anything new here really, the response that we have seen over the last 10 years, in particular the last 5 years really, from the international community, from the US government with leadership, let's say clinicaltrials.gov, from the WHO, from Europe, with also many of its actions since the implementation of GCP, has been a move towards transparency, and this move is building very fast. I want to submit to you, though, that secret science is never acceptable. And I mean, I don't want to go into other kinds of science, but science, just health science or any science with experiment on human subjects done secretly, this is not acceptable. Now, whatever regulations, whatever guidelines we have, whatever kinds of regulatory systems we build, as long as science is secret, we will do one thing. We risk the kinds of experiments that happened in Guatemala. Let us take for granted, and as in many cases in these experiments, people did follow regulations. Let's assume they followed regulations. Whether they followed regulations or not, that's probably not what's most important here. What's most important here is this was not done in broad daylight. It needs to be done in broad daylight. Now, to say something about GCP. This is a short history of GCP. It's an enormously complex history. Just European GCP is already really difficult, let alone WHO GCP or ICH GCP or FDA GCP. This is really a complex and difficult thing. The relationship between GCP and other international guidances, regulations, laws is also very complex. I don't think that we can achieve, or that we need to, or should insist on having one rule, one way of doing it. I don't think anybody at the table here would insist on that either. We have different situations, we have different kinds of concerns, and we have different aspects of our discussion that we need to be able to clarify and bring out strongly. ICH GCP is certainly the gold standard. I highly recommend you all read it. It is the clearest GCP that's ever been written. The WHO GCP from 1995 is excellent as well. There is a reason, there are good reasons why the US government moved towards a GCP framework. It is not only to do with the rejection of the Declaration of Helsinki. Rejection is not the right word here. There are also good reasons why people doubt good clinical practice. We saw this particularly in the discussion that led to the 2001 European Directive on GCP. People doubted GCP legitimately because ICH had 6 partners, 3 from governments, from the US, the European Union, and Japan, the leading countries at that time in doing clinical research, and 3 from industry, from the same regions. And there was a lack in the discussion, and that remains. We have also, within European GCP, I think what has been important and valuable for us in Europe with regard to GCP has not been the directive itself. It has been the 10 years of discussion it took to achieve the directive, and the 10 years of discussion that we're still involved with the implementation of the directive, and now perhaps revising that directive. That discussion is very valuable. That discussion has strengthened our ethics. That discussion has strengthened our ethical review committees, our IRBs. That discussion has enormously strengthened patient subject participation in research. One last slide. I apologize for going over time. I propose for the Commission that you seriously consider the common rule, to revise the common rule. That's what has to be done, I believe. There is a lot of commonness in U.S. federal regulation that is scattered over many different places within the regulation. That commonness can be brought together. And the exceptions or the differences, they can also be more rationally put together as well. I think those differences are there for a good reason. We saw that yesterday as well. But what's common there, what's common particularly between, let's say, the common rule and the FDA rules, that's common. That can be explained much more explicitly. Also, what's common internationally, that can be done as well. There's a lot, there's a great deal that is common, while also allowing for the diversity there. We need to find really an appropriate platform, an inclusive platform internationally to do this. And I think that we should begin to consider how to do this more generally. At the end of the day, what we want to insist on really is that research, we want to achieve a culture of research, not just a regulation of research, a culture of research, such that research is done in broad daylight. That's our best protection for human subjects. Thank you all.
Thank you very much.